Good morning, everyone. My name is Eberhard Grube. I'm coming here from Germany, University of Bonn, and together with my good friend and co-moderator Lars Sondergaard from Copenhagen, I would like to start the session, Issues in TAVR 2021, with a wonderful speaker panel here that we have. Basically, we have three speakers, Dr. Kodali, Dr. Jian, and Dr. Park, talking about the issues that we have in 2021 regarding TAVR. So, Susheel, would you like to start the session with your talk, TAVR for Sixties, Consideration for TAVR in Younger Patients?
Great. Thank you so much. And it's a pleasure to be a part of this panel, and I would look forward to doing it again in person next year. So I hope everyone can see my slides, and the discussion and topic here, my disclosures. I was asked to talk about is what are the issues as we talk about TAVR in younger and lower risk patients. And sort of the basic premises over the last decade, TAVR has evolved into a predictable low risk procedure for the majority of patients. But numerous studies have demonstrated that it's either superior or at least comparable to SAVR in multiple risk categories, including low risk. And given that, it's really critical that we assess the pros and cons of all therapies to help patients make the right choice between TAVR or SAVR. And the factors in decision-making in TAVR are the same as in any medical therapy. It's always risk-benefit and assessing the risk of the procedure versus the benefit. And we've done that really well in TAVR studies with the heart team, with surgeons, imagers, cardiologists, interventional cardiologists, to say what is the best option and best therapy for an individual patient. And the conversation is different in high risk versus lower risk patients. In high risk patients, clearly the TAVR is lower risk than surgery. And in that patient, the conversation is very different than a low risk patient. And I think one of the things to make clear to patients is less invasive doesn't mean low risk. And that's an important conversation to have. As you get to 60-year-old patients, the risk of TAVR and surgery is relatively comparable. And so that risk-benefit conversation really changes. But in the end, we must remember the goal is always the same: provide the best therapy for an individual patient. And the reality is that patients always prefer a less invasive therapy. And that's why it's important to really understand and have patients understand that less invasive doesn't mean low risk. Or lower risk, I'm sorry. So as patients become younger, that conversation changes, as I said, and other factors need to be considered. And these include several things which I'll highlight in this talk: anatomic suitability for TAVR, presence of concomitant disease, and as always, the durability concern. And when we talk about anatomic, one of the big things as we get to lower risk patients is bicuspid valves. As we all know that as we get to a lower risk cohort of patients, the presence of bicuspid valve increases significantly. And 20, 30, 40% of patients in their 60s are going to be bicuspid, and there's a lot of regional variability in Asia versus US versus other regions. And the issues with a bicuspid valve is there's often a large asymmetric annulus, which may lead to incomplete coaptation incomplete expansion of the valve and paravalvular leak. There's also heavily calcified raphe, which may push the TAVR valve in the opposite direction of the calcified raphe, leading to concerns about annular rupture or a non-circular deployment. And in a balloon expandable or even a self-expanding, when you have a non-circular deployment, you can get this type of, this is an acute result, and you see leaflet dysfunction because the valve was not fully expanded. And so understanding this, looking at TEE, and making sure you have complete expansion is important. Often associated with concomitant pathology such as aortopathies. But what we've learned, especially, is that all bicuspid valves are not the same. We've used the traditional Sievers classification, but now this new classification has been proposed looking at the raphe and whether it's tricommissural or bicommissural. And I'm not going to go into it, but with surgery, this doesn't impact it as much. You remove the leaflet and you sew in a circular valve. But with TAVR, we need to have a better understanding of how TAVR will perform in each of these anatomies. And we don't have that right now. And that's important data to be able to give an educated answer to our patients. One of the largest series of results that we have is from the TVT registry, published by Raj Makkar and JAMA last year, looking at approximately 2,600 or 2,700 bicuspid patients, which were matched to tricuspid patients. And they showed slightly higher rates of annular rupture and a need for a second valve. But although the rates of stroke were higher, mortalities were equivalent, and as you can see, also the pacemaker rates were higher with bicuspid valves. But again, mortality was equal at 30 days. And when you look at 1-year mortality, again, no difference. The big concern, as I mentioned earlier, is paravalvular leak, and they didn't show a significant difference in paravalvular leak between bicuspid and tricuspid valves. But it's important to understand the limitation of this analysis. This is there's a lot of selection bias. These are patients where the operator felt that TAVR would work, and so we don't know what type of bicuspid valves it was, how much calcium. We don't know all of those answers. There's also no core lab. The PVL is all site reported, and it's limited follow-up, only 1 year. So we really need to get more data to understand which bicuspid valves do well with TAVR. And I don't know that we need randomized trials, but we need better data looking at the different types of valves. And again, it needs to be longer term data. And I think that's one of the challenges. So as I'll talk later, when you're having discussions with younger, low risk patients, getting sort of longer term data is going to be important. And in the future, we may have better devices for bicuspid. We may have adjunctive devices that modify leaflets to allow better expansion, but there's still a lot to go. There's other anatomic considerations. These are anatomies that higher risk, and in a low risk person, this patient should have surgery. Conduction abnormalities. The pacemakers are not completely benign, and so if somebody, that's part of the conversation. It's less so, but that's important. The other big sort of PPM is patient prosthesis mismatch. If somebody in low risk has a small annulus and, they may benefit from a root enlargement, that's a conversation. The counter side is TAVR has better EOAs than surgery. And so maybe that patient should get TAVR, but this should factor into the conversation. And finally, annulus size may factor in. And I'll talk about that later, but if you have a large annulus and you have the ability to do valve and valve without PPM, that may lean towards TAVR in a younger patient. Whereas if they have a small annulus and you can't do valve and valve, you may lean towards surgery as a first therapy. Then we talked about concomitant pathology. Coronary disease is very common, especially in younger patients. It impacts outcomes post-surgery. We don't have a lot of data, and there's a lot of incomplete data, but we need to answer some questions. Does the patient have significant coronary disease, and should it be treated? And by significant, is it causing symptoms? ACS will impact survival. Does it impact the safety of a procedure? These are all important questions, and these need to factor into the decision-making because either it may lean you towards CABG AVR, you may plan medical therapy for the disease, or you may do PCI in the setting of TAVR, and you have to choose a strategy. And there are a lot of things that factor in. If a patient has angina, that may lean you to say the coronary disease is important and really need to factor it in. But the other end of that conversation is that the presence of CAD in a diabetic with triple vessel disease, you may say that CABG is better than PCI. And so in that patient, rather than doing TAVR, they should have CABG AVR. In a focal single lesion, it won't impact that conversation. And then the other thing is coronary access post-TAVR. And in person with coronary disease, we know that these TAVR devices with these skirts may impact and may make coronary access more difficult because right now we don't have commissural alignment as the surgical AVRs do. So that may factor into the decision-making about whether to do TAVR or which type of TAVR to do. And so these are all important considerations. And finally, the durability issue. We don't have really long-term durability data in a echo core lab. We're close to getting 10-year follow-up, but there's always going to be concerns about durability. And in the end, TAVR as a surgical valve has to be durable as average survival for the patient. And that obviously varies as we look at a 75-year-old versus an 85, which is where this conversation usually started. But as you can see, in a 60-year-old, you need to try and plan for 20-year durability. And the question that really needs to be answered if TAVR is chosen is, can we expect the patient to get through the rest of their life without surgery? And can we get through 20 years? And that's where annulus size, ability to do valve and valve, and all of those factor. And a lot of the conversations in younger patients has to be about lifetime management strategies. For example, if you do, strategy one is if you do SAVR in a 60-year-old, then in their early 70s, say the last 12 years, you do a valve and valve. If you put a 23 surgical valve and then did a valve and valve at 80, what are you going to do? Can you do a redo TAVR, or are you forced to do re-op surgical AVR? And so that's part of the challenge and question as you look at average survival. But strategy two could be do TAVR at age 60. And then assuming that the risks of SAVR are not dramatically increased in explanting a TAVR, delay their surgical AVR to near 70. And then when that valve fails at 82, you can do a TAVR. And so, there may be different strategies, and we have to talk about it in the individual patient. But the goal is to minimize open heart procedures and avoid performing them when patients are high risk. So final thoughts, in younger, low risk patients, the final thing, patients will always prefer a less invasive therapy. But TAVR needs to be as safe as surgical AVR in that individual patient. So it's important to look at the anatomy, bicuspid, LVOT, calcium, all of those factors. And the risk-benefit conversation is different as patients become younger. And the lifetime management of the patient must be considered when making the decision about TAVR versus surgery in a younger, low-risk patient. And choosing TAVR should not result in compromising treatment of concomitant disease, such as coronary disease. Thank you very much.
Great talk, Susheel. So I think we're going to take all three talks, and then we're going to have a discussion at the end.
So you'll be talking as TAVI ready for young patients, and he's obviously talking about the surgeon's perspective. James, great to having you again and seeing you up and well in sunny Vancouver.
Thanks, Dr. Grube. Hi, everyone. It is my pleasure to be a part of the TCTAP again. And today I was asked to give a talk on whether TAVI is ready for young patient from a surgeon's perspective. So I just want to say I like the technology, but today I have to give some talk on what's the disadvantage and what's the issues with the TAVI in young patient. Here's my disclosure. So as everybody knows, there's two major trials in low-risk patient which are Partner 3 trial and Evolute low-risk trial. And both trial has shown TAVI is superior or same as surgery in terms of death, stroke, and hospitalization at 1 year and 2 year follow-up. So this is the data is pretty solid, and it confirms TAVI is better based on the short-term outcomes. And here's the data from a real world from a STS-ACC TVT register in the low-risk patient in 2019. And I listed 30 days early outcomes. As you see, the mean age is still 75 years old, and the majority from 70 to 81. And there's about 1.39% of patients that actually you see either need a CPB cardiopulmonary bypass or convert to the open heart surgery or procedure aborted. That's from a real world. And the 30 mortality is about 1%, and the 30-day stroke is about 1.8%. And these data is quite compatible with the data from a randomized trial data. So based on the current randomized trial in the low-risk patient and other publications, so the ACC and AHA has published the 2020 guideline, and I just listed one figure here. And in the guideline, it is clearly stated that TAVI is listed as a class 1 recommended therapy for patient of age greater than 80 years old, and while the surgery is listed as a class 1 recommended therapy for patient of age less than 65 years old. So for the patient of age between 65 to 80 years old, and then both surgical and TAVI listed as a class 1 recommendation therapy for aortic stenosis. So the real question, I think that for the age less than 65 or age less than 80 years old, I don't think there's any debating about that. But the question for the patient of age between 65 and 80 years old. So what's the real question? Is the clinical data sufficient to support TAVI in young patient? So when we talk young patient, I think we need to be careful, not just based on age. I think it's really important to know what the expectancy of like a life expectancy, because when you talk about patient from different region, from different country, the life expectancy could be huge different. In some area, the life expectancy about 65 years old. In some area like Japan, the life expectancy probably 85 years old. So we just not based on the age. If you're based on age, 65 in some region, that's probably is not young anymore, because the life expectancy is only 65. So I think it's really important that when we talk about young patient, that we need to talk about what's the life expectancy in each individual, so in each area. So I just listed a few concerns general regarding TAVI used in the young patient. First, we look at the two trials. So this is the partner 3 trial and the low risk trial. So in these two trials, as you know, the patient enrolled in trials are quite selected, and many patients are excluded from trial, and also they are very small portion of the young patient, true young patient, and particularly age less than 65, 70 years old. In these two trials, it's pretty low portion. So the low risk is not equal young. And these trials is represented more like a low risk patient, but not necessarily represented the young patient. So I think that's important to look at it. And the second concern is, of course, the durability, and this is always a concern when you move to the young patient. I think we should not just talk about the early outcomes. We have to talk about the long-term outcomes. So there's no really we call the midterm or long-term outcome data from a true young patient. And here's a 5 years outcome from partner 3 trial. And this is, as you know, the age average about 80 or a little over 80. So during the 5 years follow-up, and you can clearly see the valve-related reintervention is clearly high in the TAVI group compared to the surgical group. As you see, as most reason for intervention is valve either regurgitation or stenosis. And also rehospitalization during years follow-up, and also quite high in the TAVI office, TAVI arm related to the surgical arm. So these are rehospitalization is related to the valve, procedure, or CHF. So definitely there is some concern even in the elder patient, as not young patient per se here. So here's one publication is trying to do a meta-analysis of 3 randomized trial and a 3 propensity matched study, trying to look at the midterm outcome, not the early outcome. I think there's so many papers, like 100,000 papers published. Most look at the early outcome, but not really, midterm or long-term outcome. I think that's a very critical. So from this study, you see here, it is clearly see the mortality, all-cause mortality as high in the TAVI group, particularly after the 2 or 3 years. And based on the hazard ratio, is also favor surgical aortic valve replacement after 2 or 3 years. So look at the data here. We have most data right now currently available for young patient or low-risk patient, not really true young patient. The outcome is really only 2 years. So if you look at right now, yes, the TAVI is definitely same as or better than the surgical approach in terms of short term. But when you look at long term, maybe this change because it's a line maybe crossed or even more further separated during the long term follow up. So we need to be very careful when we use in the low risk patient. And also there's this other concern. Today, I'm not going to talk about anatomic concern. I just give a talk about general concern. The one is the stroke, I think is still the issue. Not just like a clinical significant stroke, but also the silent stroke. As you know, the silent stroke is quite common in patients regardless of their age. So whether this is a more concern in the young patient, we really don't know. We don't know yet. And also the paravalve leak. Another thing is thrombosis and conductor system disturbance. and also the future coronary reintervention. I think that a few things we have to mention. Regarding stroke, as I said, silent stroke is high. I'm not going to talk about it too much about because of time. So regarding the clinically significant stroke, this is the data from partner 3 trial. Also, overall, it's no different at 2 years, but there's some alarming because from year 1 to year 2, the stroke rate in the TAVI arm clearly is higher than the surgical arm. You can see the 6 cases versus 1 case. Of course, there's a different detail. I'm not going to get into detail, but this is an alarm sign at 2 years. Whether this will be any different in the 3 years or 4 years, we don't know yet. So I think we need to be a little bit caution here. And also the stroke rate from a real world, is there any significant change over the past several years? Not really. You can see this is from a STS ACC TVT register. You see that over the past 6 or 5 years, stroke rate is no really significant decrease. It's slightly down, but not really significant. So I think this, when you move to the young patient, I think these are is a concern. And another one is the strong valve thrombosis. Here's also from partner 3 trial low risk patient. And at 2 years, you can clearly see the valve thrombosis in the TAVI arm is clearly higher than the surgical arm. And whether this is an important finding or not, of course, we are not really sure. But generally speaking, your early valve thrombosis could impact on the long-term durability. But of course, this needed to be further follow-up, and there's no clear data. This is a definitely impact as a long-term durability. But it's a concern. And the pelvic leak. Yes, I think we are totally agree that the significant pelvic leak, such as the moderate or severe, is significantly reduced with the new generation valve compared to the old generation. We know when we started, there's a quite a common they have moderate and pelvic leak, but now it's really not seen frequently. But the question is, mild pelvic leak is really clinical significant or not, and still don't know yet, particularly in the young patients. They are living for the 20 years or 15 years, and this is an issue. I don't think we have an answer yet. And here's the data from a partner 2 trial and 5 years follow-up, and they just shows some trend of increased mortality in patients with a mild pelvic leak at 30 days compared to the patient without pelvic leak. So there's some alarm signal, but it's not really clearly sure whether after beyond the 5 years this will be have more significant impact. We don't know yet. So another thing is, as everybody knows, a conductor system problem with transcatheter valve, particularly with self-expand valve. And the one thing that concerns the left bundle branch block. This is quite a common with the TAVI, and the data from partner 2 clearly show even the left bundle branch block is also associated with cardiovascular death. So, and for these are the 2 years follow-up. How about this 5 years, 10 years follow-up? Is this will be significant impact? I think we still don't know in the young patient. And the pacemaker, of course, with these are the from a different trial, but of course with a different use, a different technique, you can significantly reduce the pacemaker nowadays, even with Evolut or Pro. But the pacemaker clearly is a concern in the young patient compared to the old patient. So last concern is coronary re-access. I think there's a concern. For the elder patient, I don't think there's too much concern, but in young patient, yes, is a concern. Particularly for the patient that's life expectancy, 15 or 10 years, we expected the valve will fail and then need another intervention. We can use the valve without surgery, but however, you put another valve into TAVI valve, there's a more chance have a have a problem with the access to the coronary arteries. So I think that this has to be a concern for the young patient, particularly with the life expectancy of 15, 20 years. So based on the current publication and from publication as a propensity match or the from a real world data from a trial data, I think I summarize the currently available data in supporting TAVI in different age group. So I think it's very important that we need I listed the life expectancy because this is the most important thing. So when we talk about age, so for the patient that have life expectancy 20 years, I don't think that we have data show that the TAVI is same as surgical valve. I think it's agree with the guideline. I think that the surgery is clearly is a choice for these group of patient. So now the question for the patient of age 65 to 70 years old and with life expectancy 15 to 20 years, there's any strong data support. I think at this moment is very limited early outcomes data available. I think at this point, I will say surgery probably is a favorable treatment for this group of patients, unless the patient life expectancy is reduced or there's other issues. And for the patient with 70 to 75, I think this group of patients is more controversial. There's some data support the TAVI is similar or superior, but I don't think there's a midterm data is available at this point. And for the age greater than 75, I think clearly there's data show as TAVI is a favor than surgery. So I think when we talk about the young patient, we have to know the life expectancy and be very cautious to discuss every advantage and disadvantage of TAVI versus surgery when we approach any patient. So here's probably my last slide. So the question is whether there's sufficient data supported this TAVI used in young patients with life expectancy 15 to 20 years. My answer, unfortunately, is say no at this point, because there's no really strong midterm data available for this group of patients. I think when we talk about young patients, we have to look into the mid and the long-term follow-up data. Midterm, I think it should be 5 years. Long-term, it should be 8 to 10 years. I think nowadays the publication, they always say the long-term for the 2 years follow-up. I don't think that's a proper definition for long-term follow-up in young patients. So I think for the next few years, this will change when we have more data available. Thanks.
Thank you very much, James, for giving the surgical perspective. And I think we move on to Dr. Park, and he is discussing a very, very important topic, anticoagulation post-TAVR, optimal antithrombotic therapy after TAVR, the studies. Dr. Park, thank you very much.
Okay, thank you, Eberhard. And so my topic is about 10-minute brief review, optimal antithrombotic the therapy after TAVR procedure. I'm gonna review and available data. This is my disclosure. Usually looking at the chain of a TAVR random trial from the partner 1 to recent partner 3 trial, low risk Evolve trial, is all trial use the ADAPT regimen. The decision is based on the expert consensus. The reason why it's like a stand to the rationale for treatment decrease stroke risk or risk for myocardial infarction. So however, and the Raj Marker reported in New England Journal of Medicine and the recovery and savory registry shows the replete thrombosis could be problematic after TAVR procedure. The reason why we think about different concept. This is Lars Sondergaard data, is Holt and Ham, is looking at the current available data, and the more frequent inpatient on antiplatelet alone is Holt. Ham progression is more common. If you're going to use the oral anticoagulation, its regression is much common. There was know about the Holt and Ham concept. This is also partner 3 CT study shows the Holt and Ham. There was very time dependent dynamic over the time, and the overall prevalence much common after TAVR than the bypass surgery, than the SAVR, and the overall course is very dynamic. Also, we still don't know the the associated halt and ham with stroke or TIA, but the overall and the frequency or the number of the brain event much common in the patient with halt, and this is numerically higher. So looking at the current available data, some of clinical trial published, some of clinical trial is not yet published yet, and the overall looking at the reported stroke or TIA after TAVR procedure up to 1 year, approximately 10%. And looking at the overall incidence of life-threatening or disabling major bleeding, and up to 1 year, approximately 20%, nearly 2 times than the stroke or TI event. So if you define primary trial endpoint as a net clinical composite, including the major bleeding event, you can always achieve a positive result with a less potent antithrombotic strategy. This is seems to be very attractive for trial investigator. This is a confirmed ARTE and POPULAR-TAVI trial. And the ARTE trial, this is a very small-sided trial, 222 randomization. One arm is aspirin alone, another arm is ADAPT, aspirin plus clopidogrel. As expected, bleeding event much common in DAPT therapy, stroke, MI, death was no difference. Primary composite endpoint, including bleeding, much common in the DAPT therapy. And the Galileo trial, one is a large-sided trial, everybody know where, randomization 1,600 patients and the DAPT versus rivaroxaban plus aspirin in the half-dose rivaroxaban. Primary efficacy endpoint was some ischemic event was much higher in rivaroxaban group, statistically higher, and safety arm is the VAC life-threatening, and the major bleeding was tend to be higher in rivaroxaban group. All-cause mortality statistically higher in rivaroxaban group than DAPT therapy group. But interestingly, this is a CT sub-study, ITT per protocol. If you're going to use rivaroxaban, leaflet thrombosis, halt and ham, the much lower. So, and why Galileo failed? I think ischemic bleeding leverage is much complex in elderly TAVR patient. If you're going to think about ACS PCI, we can the leverage and ischemic bleeding risk, but the old age TAVR patient, usually reality is very difficult to leverage ischemic bleeding and mortality event. What about the POPULAR-TAVI trial? Is POPULAR-TAVI trial, code A is patient no requiring oral anticoagulation. Code B is requiring oral anticoagulation. Published the New England Journal of Medicine. Code B indicated for oral anticoagulation. Bleeding as expected, much higher if you're going to use OH plus clopidogrel compared to OH alone. Is mortality, ischemic stroke, MI, and ischemic event was no different. Popular code A not indicated for OHC. This is the same finding. All bleeding is much higher, more potent regimen as ischemic event there was no difference. Looking at this is if you're going to define trial endpoint, net clinical outcome, including major bleeding, you can always achieve a positive result, less potent antithrombotic strategy. But we are wondering, is it sufficient to guide your decision making? So, and look back, the recent published the updated guideline, and on the basis of the ARTE small size trial is aspirin alone is 2A, and the DAPT therapy is prior, and the chain of random trial is 2B, and the load the warfarin and 3 months is 2B, and the rivaroxaban plus aspirin is 3. Still, we don't know. And so, what a next solution is a potential in NOAC role is Galileo is the degree of anticoagulation is higher, but the bleeding event is higher, ischemic event lower. But ARTE trial, POPULAR-TAVI series is targeting for is a low risk of the bleeding, but we don't know high risk of ischemic event. This is overall is underpowered. So, and we expected ongoing trial, Atlantis trial, Envisage TAVI trial, our ADAPT trial is positioned in the neutral part and the maintaining part, and the Atlantis trial we expect is already enrolled patient, expected next this year ACC or ESC meeting, and we conducted ADAPT-TAVI trial. This is the not indicated oral anticoagulation population, and the randomization 220 patient. One arm is edoxaban versus depth therapy. Primary endpoint, 6 months cardiac CT scan. And we also simultaneously checked DW MRI at 6 months and immediate post-TAVR. Also simultaneously checked neurocognitive function MOCA, modified Ransky score, and NIS score. We simultaneously checked CT, MRI, and neurologic function test. We already enrolled complete 220 patients. We expected 1 year later is final result. This is my last slide. TAVR patient has a multiple thrombotic and bleeding risk comorbidity, and left thrombosis, heart and ham is time-dependent dynamic phenomenon, but the clinical effect still we don't know. Choice and duration of antithrombotic after TAVR still remain a matter of hot debate. Galileo was failed. POPULAR-TAVR adapted a very conservative design. This is not compelling for clear decision-making. Potential role of Newark will be further supported the upcoming random trial such as Atlantis, Envisage-TAVI, and ADAPT-TAVR trial. Thank you for your attention.
Thank you. Thank you very much. That was excellent summary of a very important topic, obviously, for us. And we would like to start the discussion. Anyone from the panel that has been listened and not really said much? Any comments from your side? Jung-Min, waking up?
Yes, thank you for presenter. It's a very nice presentation. Actually, I have one question to the James slide. I was surprised to see the higher stroke rate and the higher mortality at the valuable TAVR patient. So what's your thought to why it happened?
So this is a good question as to why the mortality and the stroke are high in the meta-analysis. I think there's several reasons. Some study for the 5 years follow-up is not truly the low-risk patient or the truly young patient, and also the valve used in those trials are not really new generation. Probably is a little bit old generation. So the patient have probably is more pelvic valve leak or other procedure issues. That's leading to the more valve reintervention and other complications. So and also the valve durability, whether this new generation and the old generation, there's a different because a different design, and also the implantation technique is improved. So all these kind of things that maybe contributed to the some high mortality or stroke rate in this study, because some follow-up means that already 5 years, and 5 years ago probably most patients that use relatively old generation, and also the center's experience and the technologies is probably different. So I cannot say whether this is a new generation or another more experience in terms of better technology, whether this can improve the outcome. So I think it's a remain unknown. I think the more data needed, particularly from partner 3 trial and the low risk trial. I think that's very critical for the next few years data. Thank you, Dr. Yang.
Yeah, I have a question regarding as we move forward, particularly about the surgical and the interventionist view of younger patients. When we move along, question to all of you, when we move along, should we say TAVR irrespective of the valve using, kind of calling it a class effect, or should we specify this is not TAVI, but this is, for example, compare between S3 and surgery, Evolute and surgery, because maybe we have some points of portico or actually, as we move along, might actually be differences between the different valves. What's your opinion about that? DDA, you have used, most of the devices. Would you all summarize them under TAVI, or would you specify as we move into younger patients, specify specific valve versus surgery? What's your opinion about that?
Yeah, I think it's a really critical point that you've raised, Eberhard. I don't think that anymore we can call it a class effect, because we all know that there are different patients, different anatomies. We are dealing with patients of different ages, different life expectancies. So we really need to adapt the device that is going to fit most to the patient we're going to treat. We are going to see in the upcoming years head-to-head comparisons of TAVI devices. We've seen that, for example, with the Scope 1, Scope 2 trials, that there are differences. So we need to take this into consideration when we are dealing with a single patient. I don't like to say that one device is superior to the other one, but I truly believe that for a dedicated, a specific patient, we have differences, and we should select the device that fits the best to this patient. We've seen from the surgical literature, just to keep it short, that there are differences in terms of bioprosthesis, because the durability is not exactly the same. If you take a Paramount or a mitral flow, for example, and probably accumulating data about the durability of the current TAVI devices, we're going to see differences. We have differences in terms of position of the leaflets, hemodynamics, gradients, regurgitation, and so on. So we will need to explore that in the future. So I would conclude by saying I don't think that there is a class effect. We're going to see differences considering the devices.
Yeah, it's John here.
Yeah, thank you.
I think durability may vary dramatically with these valves, but we really don't have any idea which are really going to be the really durable valves and which one is going to really fail us. But I think we're going to have some embarrassments in the future with some of these valves in terms of durability. Coronary access is certainly an issue in younger patients, but maybe the most important issue is whether these procedures are repeatable. And I have to say, looking back at my experience over the years, it's pretty common, even with short valves, that we have the valve extending up above the coronary. And this may predict the inability to repeat TAVI, which is really fundamental to the TAVI strategy. So in future, we're going to have to really plan the procedure and plan the specific valve that's implanted such that this is a repeatable procedure in low-risk patients. Otherwise, we're going to be, I think, embarrassed 10, 15 years later, even with the very best valves. In terms
I was going to make the same comment. I think that's part of our discussion when we have with patients in valve choice, to Didier's point. We have to think about, we don't think of TAVI as, in younger patients as the therapy and done. We're thinking about the next procedure. And I think that impacts a lot of the decision-making. And, I'm curious what, James and Vinny as surgeons think, the strategy of, understanding that you're going to need surgery in your lifetime, doing TAVR first and explanting the valve. How complex is that surgery? And is this something that we're discounting when we talk about the strategy of doing TAVR and delaying their first surgery and trying to get them through life with one surgery?
That's a very interesting question. And the TAVR explant registry, we have already seen that there's a learning curve effect as well. There are different challenges with different designs. So I think as the field gets mature and the learning curve, is overcome, the aim of the TAVR explant would be get it to a level of isolated SAVR. And I think we are not there yet. At present, the mortality is high because many patients come with, say, endocarditis or multiple valvular lesions, need ascending replacement for dilated aorta. So I think as experience will increase, the aim will be to bring it to SAVR. And I think, to your point, that will be a win if we can get it there.
Vinny, when we talk about these devices, they're different devices, as Didier pointed out, and I agree with him. The surgical procedure is also not standardized. So if we go to Japan with very small annuli and very small valves, and compare this to the other Caucasian populations, if we have a surgeon that is not ready to put the largest possible valve into an annulus, the whole situation, the whole discussion will be turned upside down on a general basis. If we have a surgeon that's not willing to take more time to have a root enlargement, or the risk is too high, whatever, I think talking about surgery in general also needs some specifications. If we talk about the surgeon who's willing to do this, or surgeon, conservative or whatever, a surgeon we talk about and putting in a small valve, then clearly the strategies that Susheel pointed out will change. It's going to be a very difficult situation, and I'm not sure whether we can generalize that. Take a little bit more a location or geographic or whatever approach.
I think that's a great comment. I think one thing I just want to say, we talk about a small aneurysm. We say nowadays we always say trying to use a TAVI. I actually the opposite than that. The idea. The reason is because you redo a surgery is definitely is more complex than the initial native valve. And in the young patient, the mortality for isolated AVR, it's really like 0.5% or even low in the experience center. So my concern for the small aneurysm, for the young patient, I think we should surgery do the root enlargement. As Dr. Grube said, I think that's very important for the surgeon to understand that you put a small valve, you will be a problem, either with a TAVI or with surgical valve. I think a root enlargement is pretty simple procedure. I think for these kind of patient, maybe in the future should send it to the experience center to do this kind of procedure rather than every center to perform this kind of procedure, because in the future aortic valve replacement number will be significantly decreased. And I think we should centralize this kind of procedure in the future and to do as a little bit better job and best for the patient.
So James, I think this is a very good comment, but most surgical sites do not do root enlargement. It's a very few patients who actually come out of the OR. So Kentaro, can I ask you, if you want to look at lifetime management of these patients, you have to take all these anatomical considerations into your decision making, the risk of PPM, the access to the coronary arteries, pacemaker risk, PVL risk. How's a heart team working at your institution nowadays? Do everyone need to have a CT scan up front, no matter whether they're going to end up with a surgical or transcatheter aortic valve replacement?
Thank you very much for your question. So actually, we all review all the patient in our hospital by taking CT scan. And we put all the patient to the discussion with surgeon, and which patient is suitable for surgeon and which patient is suitable for the TAVI procedure. And some surgeons are doing root enlargement in Japan, but some are not doing root enlargement. And according to our TAVI database, we only observed severe prosthesis patient mismatch in 0.8%, but that is the 10% in United States, maybe presumably due to small body size of Japan. So we are usually choose the TAVI procedure for the small patient. And in most of the centers that we all review all the patient together with surgeon, but not in the non-TAVR center. That is a problem.
Can I ask the last question before we turn over to, I'm sorry.
Can I just make a quick point? Means I think we have eminent cardiologists and great heart teams here. As in Columbia and now in Minneapolis, means we discuss which TAVR size we're going to use based on CT scan. We still don't discuss which SAVR size using CT scan. I think that equation, which Susheel is already nodding, we have been using for many years now. So if I feel on the CT scan, this is the size I'm going to implant, that's not good for the patient, we discuss root enlargement upfront, and we expect that the patient will get root enlargement. So I think we still need education in the surgical community for that.
Yeah. Last question to Dr. Park. Very important topic, ACC guidelines 2020, the last European guidelines 2017, kind of old given the information that we have. Is it comfortable with using single antiplatelet therapy as being recommended? Or are you still using dual antiplatelet? Any comment?
So my comment is that I think this concept is this concept is like some bio-creep in the non-imperial trial. In the bio-creep means less is more concept, less is more concept, less is more concept. But I think that is finally placebo is good as a standard treatment. You know, some physician or some fellow is question, how about skip the aspirin alone, just not prescribing everything? Might be looking at clinical endpoint, less bleeding, but we don't know. I think some still don't know exact answer for that. Is current available clinical trial do not probably require some more, the ongoing clinical trial.
Okay, I think Lars, we're finished with the first part. You take over for the second one then.
Yeah, and I think that was a very good comment from Dr. Park, and maybe also we're very simple looking at antithrombotic therapy in these patients, treating them all with the same way. Maybe we should be more individualized in our treatment option for the patient. So we're going to move to the next part of this session. It's about the future of valve intervention. The first talk will be on transcatheter valve replacement for failed surgical bioprosthesis, and I think we have the best speaker we can have in this field, Vinny Bapat, please.
Thank you. I hope you can see the slides.
Yeah.
This is, again, I think, taking the theme forward, partly what we have already discussed. These are my disclosures. This is our first valve-in-valve, or one of the early ones in 2010. This is a third time re-op transapical procedure, but still a great procedure. Patient was home early, was playing football or soccer with his kids next week. The question main today is, all the patients technically expect or want a valve-in-valve, and should we be doing it? If we look at the valve-in-valve literature today, it's a very well-established treatment. We all get a lot of patients. We have got, I think, acceptable midterm results, but mainly in high-risk patients. And it doesn't mean we won't get good results in intermediate risk patients, but our expectations from the procedure was low as well. In small valves, there is still a challenge because of the Russian doll effect. And hence, I think we need to understand as a heart team, when we consider these procedures first, can we optimize the result when we are doing the procedure? And if we can't, then should we actually consider surgery? And that's the biggest question, because these are reoperations as well. So from a surgeon's perspective, if I can quickly in 10 minutes summarize how to optimize the result from different designs, what are the issues with small SAVRs, and what we are trying to do, will it work or not? Risks of coronary obstructions and the treatments currently, the issues with TAVR explant, which has been addressed in the previous session a bit, and concept of lifetime management. I think to optimize result, it's very clear that each valve is not same. So even today, sometimes when I sit in our meetings, people say Edwards 25 valve or Medtronic Ring 32. It actually doesn't make any sense because the dimensions are very different. So when you're considering a patient for valve-in-valve, definitely make sure that you identify important dimensions. And we have shown this many years ago now, that something called as a true ID is the ID you should be looking at. And if you have a porcine valve, the true ID is obviously least compared to a valve which has got leaflets outside. Ideal implantation is discussed quite a lot, zone 0, zone 1, zone 2, etc. But I think the issue with ideal implantation is, one is you have to have a secure TAVR or a valve-in-valve, and at the same time have a best hemodynamics. Now, the current or the next slides may not be for the expert panelists and the moderators here, but mainly for everyday user. So one of the important things then you have to understand is, what is the fluoroscopic appearance of your TAVR device? Because we need to know where the leaflets or the base of the leaflets are. This is very important, especially you're considering evolutar, which we do in small surgical valves. Just to show you an example, these are two bench stays. If you can see, the ideal implant would be the one on the left side. The middle screen shows how it was implanted in the Carpentier-Edwards porcine valve. And if I just superimpose the leaflets of the evolutar, you can see that the ideal implant will have a supraannular positioning, while the non-ideal will actually be behaving like intraannular. So although you chose the right device for the implantation, the hemodynamic results were not optimized because your positioning was incorrect. And I think that is what is very important to understand what surgical valve it is. And with recapturability, with a reasonable go, you should try and achieve the best implant. With SAPIEN 3, there are some interesting factors. And one of the things is differential shortening. And more importantly, is differential reduction because of the true ID. This is just to show you some bench testing that if your internal diameter is say 21 as against 19, SAPIEN 3 is going to shorten less in the bottom panel. And that can impact the leaflet mobility. Susheel showed a great example. If the valve doesn't expand fully, it can tether one of the leaflets. So we need to be cautious of that. And this problem may in future go away because we are fracturing valves or we are expanding valves. But if you are using SAPIEN 3 specifically, you need to understand to get optimal position, you also need to understand the relationship between the true ID and the expansion of the SAPIEN 3. Very small, very specific issues with small valves. Now, Lars Raj has published a lot on this issue, and it always comes to my mind that these were in native TAVRs, native valves, and what would be the incidence involved in valves. So we are doing a careful CT study now in aortic valve in valves specifically to see if there's a higher incidence of halt or ham in these patients. I actually would be surprised if there is significantly, slightly or significantly higher incidence of this. And I think we need to keep a watch on this as well. There's a lot of talk of, all of us commonly do balloon dilatation, and this is a Hancock device, which like trifecta cannot be fractured. And you can see that when you implant a TAVR device, the initial shape, which is the middle panel, is not at all to what it should be. But more importantly, when you balloon dilate it, you can see that the middle portion kind of balloons out, while the rest of the TAVR device remains the same. Our feeling again is that we are modifying the TAVR devices when we are doing the balloon dilatation, which again can impact hemodynamics in future. What about valve fracture? Valve fracture is currently commonly performed. There are a lot of questions around it. Some valves cannot be fractured. I recently found out that some models of Mosaic cannot be fractured as well. But my worry is when you implant and fracture, what will happen to the leaflets? This is a case of SAPIEN in MAC where we are post-dilating it. This is not even a true balloon, to be honest. This is actually the same balloon with a bit extra cc. And what I want you to observe is what happens to the leaflets once the leaflets and we test the valve. It's impressive to see that the valve actually has imprints of the stent. This must be damaging the stent, and this may not affect durability. But I think if we are doing true balloon fractures, we should definitely anticoagulate these patients for 3 months minimum, because this can probably form a nidus for thrombus. There's a debate about what balloon we should use, and that's why, because of these observations, we tend to start with the smallest balloon, which is 2 to 3 millimeters more than the stent ID. This is just to, again, this is not for expert users, but day-to-day users. If you're fracturing a valve, you need to see loss of waste in the balloon, as well as drop in the pressure, and start with stent ID with 2 or 3 millimeters. This will probably minimize the damage to the TAVR leaflets. Some of the protocols, hence, we have instituted is now, since balloon fracture happens at high pressures, what we do is we fracture it before, implant the TAVR, and post-dilate it with the same balloon, because now the pressure is, of course, lower because the valve's already fractured. It's also important that if you're considering fracture, you implant the TAVR device at adequate depth, because as you enlarge the diameter, the device is going to shorten, and zone 1 can become zone 0, and the valve can embolize as well. Coronary obstruction, very quickly, we know the risk is much higher if it's a design like trifecta or MitraFlow. VTC distance has been an excellent guide. A VTC distance less than 4 is usually considered as high risk, but in my mind, if it's a porcine valve, for example, we know that the true ID is 2 millimeters smaller. So in fact, in porcine valves, the risk is slightly less than the pericardial valves. The options for treatment can be many, PCI basilica being commonly used. I think we need to understand if patient is intermediate risk or high risk, what is the risk of stent thrombosis, which has been reported, if there's a need for anticoagulation. And then finally, of course, we should debate whether we really need to take those steps considering life expectancy of the patient. TAVR explant has not been easy to start with, and I think we are getting better with that soon. We can see that taller devices, there could be damage to ascending aorta or annular damage. With the balloon expandable devices and mechanically expandable devices, we have seen there's a risk of damage to mitral valve and conduction tissue. I think this needs a lot of education and, of course, awareness as well when we are explanting TAVRs. And this is going to be quite challenging if we're then doing a valve-in-valve explant as well. This is just an example of a patient to show you that there are limitations. This is a patient who had a trifecta 21, treated with Evolutar 23. And then in 14 months, we had to reoperate this patient, albeit with higher risk. And I think these are the patients which we should discuss more proactively in terms of what are we expecting in a given patient with longer life expectancy. So which patients should we not do valve-in-valve? I think the same algorithm as we talked about TAVR in low-risk patients, really. Risk of redo surgery, life expectancy, and risk of high gradients and coronary obstruction. I think high gradient and coronary obstruction being the highest risk points in the valve-in-valve, while the risk of redo operation is to counterbalance it and then to match it with life expectancy. This is just an example of the patient I showed. These are the typical patients where we discuss thoroughly whether we can do surgery or not. While a patient like this, I'm always going to support a valve-in-valve because whatever you do in these patients is going to be high risk and probably valve-in-valve is better. Concept of lifetime management, I'm not going to speak a lot about it, but I think the onus is on the industry as well. They should provide us with better products which can match each other. And if we get that, then I think we can do valve-in-valve with a longer goal of no reoperation. So I think what I coined the term as smart surgery, we need to, as we said, use CT scans for sure. But for aortic valve, use the largest valve, more durable valve which can have good markers for valve-in-valve as well to get the best hemodynamic optimization. And for mitral rings and valves, we don't discuss this at present, but we need to start thinking in the same terms to reduce the risk of LVOT obstruction, for example, and to reduce the leak of non-circular ring and the results which we have seen in the registries. So I think pre-planning is very critical. Inspiris has been one of the, I think, the first valves which has come in the market. This valve, of course, most surgeons use it because the tissue science is supposed to be more durable. But I think most of us also favor it because it can be expanded in future at lower pressures. We need to see such innovations in future. These are some of my observations in my bench study. I know there's a trend to use more porcine valves in the mitral. This makes sense. If we put a valve-in-valve here, you can see that the porcine leaflets shorten more than the pericardial. This actually might reduce the neo-LVOT obstruction risk in such patients. Similarly, in rings, you can see that some rings can be circularized, some rings cannot be circularized. Now, we need newer rings which can be modular so that they can adapt to a TAVR shape in future. There's a lot of opposition in the surgical camps regarding this concept, but I think slowly and surely this will be one of the norms as we have seen in the TAVR field as well. So in summary, choosing the right patient is very critical. If you are using the TAVR device, use the right TAVR device and right position, of course, and aim to get longer good-term results. And I think lastly, it's not just because I'm a surgeon, but I think one of the things is not to rule out surgery if the life expectancy is longer and your results are not going to be optimal after valve-in-valve. Thank you.
Thank you, Vinny. So before we have the discussion, let's move on to the next talk. We're now going to leave the aortic valve and going to the AV valve. So the first talk will be given by John Webb from Vancouver in Canada, future journey in transcatheter mitral valve intervention. John, please.
So how to address this? I don't really know. I'm going to do a brief survey of what we're doing in terms of transcatheter valves. Now let me see if I can advance this. There we are, my disclosures. So, you know, we're in an interesting situation right now. We have pretty good evidence for leaflet plication as an established therapy, or dramatic results, I think, from COAPT and other studies showing reduction in hospitalization and reduction in all-cause mortality at late follow-up. So this is, I think, really now part of the standard armamentarium in competition with surgery in specific patients. We have new variations coming. We have new versions of the MitraClip with longer and broader arms, and that may carry new risks with them in terms of leaflet tearing and so on. We have alternatives, including the Pascal device, which arguably has some advantages in terms of the spacer and independent leaflet grasping, and certainly with competitive outcomes in very early evaluation. But many patients still are not well suited to leaflet plication. Patients who have restricted leaflets, calcification in the grasping zone, very low mitral valve area, rheumatic or myxomatous degeneration of the valve, complex disease, and small mitral valve area. So there's some patients that just aren't optimal candidates. Admittedly, many of them are getting treated with MitraClip, and they may have some advantage in certain situations, but we need alternatives. Now, there's various approaches to mitral valve repair other than leaflet plication. There's indirect angioplasty, such as with the Carillon device and other devices that approximate the anterior and posterior portions of the mitral annulus. Some of these may have advantages, particularly in patients who have left ventricular dysfunction and left ventricular remodeling. You know, we include in here Cardioband, and this is direct annuloplasty now, Millipede, mitral line, Ankura, and others. Here's the Cardioband device. I think most of us are familiar with this, but I'll just show a brief video just showing transeptal implantation of this adjustable ring, and this really can be very effective in terms of annular remodeling. But I think most people would agree it's a very complex procedure. Procedure time is long, but admittedly, procedure time will come down just as MitraClip implantation time has come down. But there may be a specific role for this device as well. Clearly, though, the results aren't quite as good in terms of reduction in MR with some of these newer procedures. We have various chordal devices, including Neocord, Harpoon, and others that can be very effective in selected patients. And then, of course, we have mitral valve replacement. Now, there are many different mitral valves that have been implanted. And this is just, well, this is the majority of them actually in this slide, isn't it? We've got CardiAQ, which of course was the first that Lars is very familiar with the transeptal approach. And the subsequent iteration of this is the Evoque, which is primarily implanted transeptally, has tremendous advantages, much more reproducible in the original procedure. Now, you know, all of these valves vary in terms of their advantages and disadvantages. And here's a sampling of the valves that are currently undergoing trials in North America. They vary not only in the manufacturer and in the frame, although they're all pretty much self-expanding. The anchoring varies from a perimeter oversizing, an apical pad with a Tendyne device, you know, the interesting alto valve, which actually expands right against the walls of the left atrium, and then incorporating the leaflets or the annulus itself in anchoring. And this obviously means that some patients will be suited to a particular valve and not to another one. Delivery varies. I think transapical was how we started with most of these valves, but really this is clearly moving towards a transeptal procedure, which is perhaps less invasive and less risky ultimately. And then also as to whether they're recapturable or repositionable. This is highly variable between these different valves. But in future, I think we're going to want to be able to put them in and reposition them and maybe even take them out if it's just not working. That'll be expected. Okay, so now here's just a very short video just to show how one of these transeptal procedures would go. This is the CardiAQ. Sorry, this is now the Evoque valve, the descendant of the CardiAQ valve. And I would just point out how different this is than TAVI in the early days, and that we have a very controlled procedure, very relaxed procedure, very exact positioning this valve, just like MitraClip, and a different skill set entirely from what we utilize for the aortic
switching
valve.
beta. Perfect, good.
I'll just let this play out.
Capsules coming back here. Yep. Keep going. Keep rotating. We're wanting them to come all the way 180. There you go. Expanding.
So Lars would have to tell me, but I suspect this is a much different procedure than he performed transeptally years ago.
There we go. Okay. Valve is released. Valve is released. We should have function now. Yeah. Such a good thing. What's that? This
Percutaneous closure. And with the first valve, of course, to get CE mark approval is the Tendyne valve. And this valve, of course, is anchored at the apex. It's a transapical design. The outer frame is contoured to the mitral annulus. Still significant problems with the risk of LVOT obstruction, such that many patients are screened out for this device. And this is certainly a major problem with transcatheter valves. Although we sometimes talk of the transcatheter valves as being agnostic to anatomy, this is obviously not the case, because all of the different programs have various, very relatively large numbers of patients being excluded. Still, here's some data from the first 100 patients, really excellent results with this device, technical success and 96%, no mortality in these patients, no strokes, no emergency surgeries, no ECMO required. And typical of transcatheter mitral valves is that if they're put in successfully, they work extremely well. They tend not to have much in the way of paravalvular leaks. They relieve MR much better perhaps than the repair devices do. And given this was the first device that received CE mark, but not the last, I'm sure. You've got the Medtronic Intrepid, and I'm not going to go into detail about all of these valves, but similarly dramatic results in terms of reducing MR and applicable to a wide array of anatomies, but not all. We've got the Edwards SAPIEN M3 system, which takes advantages of the experience we have with mitral valve and valve implants. And mitral valve and valves have become pretty routine, certainly in our center and many others. And this just allows you to put in a docking, a dock, first of all, just like having a surgical valve, and then basically doing a mitral valve and valve implant within it. And here's one of the very first cases with this mitral annular ring inserted first, which is the hardest part of the procedure, and then the valve and valve implant, which adds about 15 minutes to the procedure, and really very excellent reduction in MR in selected patients. Now, one of the problems with all of the transcatheter mitral valves has been the risk of LVOT obstruction, and we all know this is a very serious complication of this procedure, and is one of the main reasons for excluding patients from various devices. But these transcatheter mitral valves vary dramatically in terms of the risk of LVOT obstruction because of their size. And for instance, with the SAPIEN Mitral 3, you do pull the anterior mitral valve leaflet away from the LVOT with the ring you've inserted. And other valves are now pretty much all incorporating some sort of strategy to reduce the risk of LVOT obstruction. And I'm sure that in future, these valves will have a standard feature that reduces this risk, but doesn't obliterate it entirely. So we've got a number of different transcatheter valves. These are the ones currently undergoing trials in North America. And the bottom line is we just don't have a whole lot of data. There's still only around 300 patients that have received transcatheter mitral valve implants. It's pretty clear that the risk of complications is probably a lot higher than leaflet plication. And the durability is really still something we don't know much about. It's pretty clear that in the mitral position, durability may be less than the aortic. We may have more thrombosis. That seems to be the case. But nobody's really had these long enough for us to know what the durability of these is. We do know one thing, though, about transcatheter mitral valve replacement is that it's probably going to be a repeatable procedure in most patients. And if you look at most of these valves, you can see that they would be patients with a leaflet failure would potentially be candidates for implantation of, say, a 29 millimeter SAPIEN 3 valve. Generally, the valves have an internal diameter that would be appropriate for that. And I think newer valves are actually often, that is the intention, that people are aware that this would be a possibility down the road, is transcatheter mitral valve in transcatheter mitral valve implantation. So when we see patients in future, I think, we're going to first, look at the type of mitral insufficiency they have and what the mechanism is. If they have primary MR over on the left and they're not high surgical risk, then surgery is probably the way you should go. If you have a flail, for instance, then surgery is probably optimal. If they're high risk, then transcatheter treatment. If they have a secondary MR and they're high surgical risk, they probably should have a transcatheter procedure unless they require surgical revascularization. And when we talk about transcatheter treatment, we're going to look at whether repair is feasible, and if so, currently that might be an advantage for us. If it's not feasible, then transcatheter mitral valve replacement is an option. Now, we often talk about mitral valve repair in the context of surgery is better than being better than replacement, but I don't know that we can really extrapolate that to transcatheter mitral valves. The implications are different. If you can put in a transcatheter mitral valve at lower risk, this may be better than a less complete repair procedure. We just don't really know, but it'll clearly vary from patient to patient. So when we see an individual patient, we're going to look at the advantages and disadvantages of each of these options. Here you can see at the top with edge-to-edge repair, and green is the favorable sort of patient. In red is the less favorable patient. So patients with commissural perforations, clefts, severe calcification, Barlow's rheumatic, small mitral valve area, just might not be so good for edge-to-edge repairs. Patients with annular dilatation, annuloplasty may be desirable, but if there's mitral annular calcification, maybe not so much. Chordal repair, patients with prolapse or failed, perhaps very good. Patients with calcification or tethering, perhaps not so much. And then replacement, there's a wide array of patients that might be suitable, but down at the bottom in red, you can see that there are going to be many patients that just aren't very good candidates if they have problems with access, if they have subaortic obstruction, if they have the risk of LVOT obstruction, then replacement, again, not so much. So at the end of the day, I think we're going to be in a situation where, at least for the foreseeable future, leaflet plication is going to be safe and effective, and it's going to be the one thing we could seriously consider offering many of our patients. But there are many patients that aren't good anatomic candidates. Residual MR is common, although we're getting better and better at this. Durability is variable, and importantly, leaflet plication isn't at some point a repeatable procedure. That is, you can't do a transcatheter mitral valve implant inside a clipped valve. Now, that's not quite true because people are sometimes using electrical therapy to sever the clip, but I don't think that's going to be standard for any of us for a long time. Annuloplasty, chordal repair, we just don't know what the place of these is. They certainly can be safe and effective in selected patients. Whether these are really generalizable, whether they should be combined with leaflet plication, nobody really knows, but this would be a very difficult and costly strategy of uncertain durability to be combining plication and annuloplasty routinely, and I don't see us really going that way in many patients. Valve replacement clearly can be more effective in reducing MR. To some degree, it's agnostic to anatomy, but certainly not entirely, particularly with LVOT obstruction risks. And one advantage is it may certainly be repeatable, that is, you can put another valve inside the first one, but it clearly carries greater risks in terms of thrombosis and cardiac injury at the time of the procedure. So the bottom line is that in future, we're going to need an entire toolbox of therapies, and we'll just have to wait and find out what they are. That's it. Thank you.
Thank you, John. So let's go to the final talk about tricuspid valve intervention, where we now, so Horst Sievers is going to give us that lecture.
Thank you very much to the organizers for the invitation. I was asked to, let me share my slides here. I was asked to talk about tricuspid valve interventions. Where are we? These are my disclosures. Let's start with how frequent severe tricuspid regurgitation is. And you can see here from different statistics that in the general population, the incidence is about 0.8%. But when it comes to MitraClip, TAVI, SAVR patients, or other patients we treat in the cath lab or in the OR, you can see that the incidence of tricuspid regurgitation is between 10 and 20%. So this is a frequent disease we encounter in our patients. The prognosis of tricuspid regurgitation is bad, and this shows the outcome in patients with left heart failure. And it is much worse when there is at the same time significant tricuspid regurgitation. So all these patients have left heart failure. This is no and mild TR. You can see the combined endpoint here. But when it comes to moderate severe TR, really the prognosis is very bad over time. Tricuspid regurgitation reduces survival in patients with mild, moderate, as well as severely reduced LV function. So the left part of this slide is important here. These are patients with mildly or moderately reduced LV function. And even in these patients, the presence of TR is a major prognostic factor. This is the combined endpoint of patients with no and mild TR. And here you can see patients with significant TR, the prognosis is much worse. Catheter treatment of tricuspid insufficiency is there are more technical challenges compared to other valve interventions like proximity of the AV node and right coronary artery. Leaflets and chordae are thinner than mitral. The annulus is softer. There's a thin wall of the right ventricle. Many patients have pacemaker leads. Patient selection is difficult assessment of symptoms, variability of clinical status. The question is always, when is it too late and when too early? Imaging is difficult, and all techniques are in an early stage, and for that reason, less than probably 2,000 patients have been treated with all the devices together worldwide. These are the transcatheter tricuspid repair and replacement techniques which have been developed over the last decade, and some of them, two actually of them, Mitraline, Triline, and Fortec, have already disappeared, but the others are still ongoing, either in preclinical or clinical trials. This shows you an example of the conventional mitral clip used in the tricuspid position. This is before after, so this works quite well with the mitral clip developed for the mitral valve, and it has been shown to be effective regarding reduction of tricuspid regurgitation, as well as improvement in symptoms. You can see that about 70% of these patients are in heart failure class 1 or 2 after the intervention, compared to the majority being in 3 or 4 before the intervention. There's now the new TriClip available, at least here in Europe, which has a steerable sheath for the tricuspid valve, which makes the implantation of the mitral clip in the tricuspid position much more easy than in the past. Then we have the Pascal device. It's another edge-to-edge repair. There's a spacer between the valve leaflets. It has longer pedals and independent leaflet clasping. It has CE mark for mitral and has also been used in the tricuspid position. From Edwards, the Forma device is a spacer which is mounted on a rail, and this rail is anchored in the right ventricle as well as the subclavian vein. So this basically occupies the space between the leaflets of the tricuspid valve. The Mitral device is a different concept where a spiral is inserted in the space below the tricuspid valve, and then the spiral is rotated and it brings the chordae of the tricuspid valve together, and this reduces also tricuspid insufficiency. As you can see here from this case, from our center, this was before, and this was, I think, 3 months after device implantation, a huge reduction of tricuspid insufficiency. Triptar technique, you puncture the right atrial appendage, get access to the pericardial space, then a circumferential implant is delivered along the atrioventricular groove, then tension is applied and adjusted, and finally the right atrial appendage puncture hole is closed with an umbrella closure device. Millipede device, also originally developed for the mitral position, has been used in the tricuspid position. It's an annuloplasty device. Then we have the Cardioband TR, also the same concept as developed for the mitral valve, has been used in the tricuspid position. It now has CE mark for both mitral and tricuspid insufficiency. The Meyer device, polycore anchors, and the thermoplastic elastomer. These anchors are placed into the annulus, and then the tissue shrinks between these anchors. A preliminary experience in 5 patients, no adverse events related to the device, and the tricuspid valve area could be decreased by this technique in this early phase. Da Vinci system, a scaffold is positioned on the annulus, and then a ring and stakes are attached to the annulus in a single shot, and then the ring and the tether cord remain in place. The tether cord is secured below the skin at the shoulder, and then after 30 to 90 days, the tension on this string is adjusted, and this is reducing the diameter of the tricuspid annulus. When it comes to tricuspid valve implantation, valve in surgical valve is something we do since a long time. This is a bioprosthetic valve in the tricuspid position. This is a sapien valve, which is inserted into this bioprosthetic valve and then inflated there. So this is common practice since many years. But there are also ectopic valve implantations where the new valve is not implanted in the annulus of tricuspid valve, but instead here in this example in the superior vena cava and the inferior vena cava. So basically the right atrium is becoming part of the right ventricle, and the symptoms of congestion are eliminated by these valves. A different concept, kind of an endograft, which is fixed in the superior vena cava and the inferior vena cava. And then the endograft has these openings here, which act as a valve. So again, the right atrium is becoming part of the right ventricle with this ectopic valve implantation. But there are also many attempts to implant a new valve into the native annulus, and they are listed here. Let's start with the Navigate. This is the valve we had some initial experience with. The problem with all these techniques is the big sheath. So this needs an outer diameter 42 French sheath. The valve diameter goes up to 52 millimeters. It can be a transjugular or right atrial access. With the transjugular access, the problem is you need an internal jugular vein of more than 40 millimeters at least, and you need a 7 centimeter space between the sheath and the tricuspid valve. And this is often not the case, so that's why the preferred access for this technique is a mini thoracotomy on the right side, going to the right atrium, and then get access to the tricuspid valve. You can see one of our patients. This is before, and this is after implantation of this Navigate valve in the annulus of the tricuspid valve. A different valve design is the Trisol valve. You can see here the difference to the other valve designs. This will allow a transjugular approach with a 30 French delivery system. The anchor valve, the valve anchors on the leaflets. It can be repositioned and retrieved. Animal testing is ongoing. We are hoping to start first in man for sure this year. Then there is the Evoque tricuspid valve, transeptal technique, 28 French, comes in two valve sizes, 44 and 48 millimeters. This valve engages the leaflets, cords, and the annulus. You can see synurands. No, they don't work. Then the Luxe Valve, which has been developed in China and used in Korea. You can see the concept here. It has an anchor which sits on the interventricular septum, and the other part sits on the annulus. It has been used now in, I think, more than 100 patients with very good clinical outcomes. Then the Croy valve, a completely different system where we have kind of a spacer which is sitting in the tricuspid valve area. It's fixed in a stent which is in the superior vena cava, and inside of this spacer there's a small biological valve. So you basically reduce the diameter of the orifice of the tricuspid valve, and the second valve here helps to reduce function of the valve. And the Vidine transcatheter tricuspid valve replacement, the valve shape matches the patient anatomy. It's compatible with a broad range of annular sizes. It uses a 28 French system. It's a transfemoral delivery. And what is unique here is the implantation technique, where the valve basically comes from the side and enters the annulus, so the delivery system is not entering the right ventricle at all. So really, tricuspid valve interventions have taken off. Thank you very much for your attention.
So thank you, host, for that talk. So let's now move to the discussion. Maybe I can start with you, Susheel, going back to this valve and valve talk Winnie gave about the sequence of revalving these patients with longer life expectancy. Do you think it's going to be possible to have a patient at a younger age? Let's say he's 60 or 65 years of age. He's undergoing TAVI procedure, local anesthesia, home next day. And when he's 10 years older, you're going to say, now we're going to do surgery on you and explant your valve and put a surgical valve in. Do you think patients are going to accept this concept?
Yeah, I mean, I think as long as we have an honest discussion, right? I mean, because the scenario is a 60-year-old is still working, and maybe he doesn't want to take 3 months off or it impacts his business. He's in a greater stage where, quicker recovery, getting back to normal activity is important. And at 70, or 72, he's retired. And but to truly understand and have that conversation, we have to understand what is the risk of removing. Is one valve different from another? And if we can give those details, I think patients accept that. I mean, I would, right? If I'm 60, I'm in a different stage of my life than if I'm 72. But I think we need some data. And if we make the surgery a lot higher risk and that surgery then becomes a root replacement, that's a different story. And I think that's where I don't have the understanding or the data to have that conversation in full detail.
And maybe I can ask you, Wojciech, we're talking about moving to this patient at a younger age. Do you think is it ethical correct? I mean, if you look at the trials, the data we have now, even though we say it's low-risk trials, mean age is 74, very few patients was actually younger than 70 and none was younger than 65. Highly selected patient who was ideal candidates for TAVI. Or do we need to see more randomized trials addressing these patients?
I think that's
that we need to see the more thorough follow-up of the patients who were implanted. So probably we treated the TAVI as a definite procedure, and now we should probably put more attention to the screening and then afterwards the procedure to do the proper follow-up with the echo. It was not really widely accepted, but now we learn to follow up the patients for increased gradients. Also, after 3 or 4 years, probably the background medical history may have an impact on the AF, stroke, progression of the conduction disturbances. So probably those patients should be followed up for the gradients, for the valve durability, as well as the AF coronary disease. So I think that if we accept the fact that we should address the patients at lower risk, but not necessarily younger patients, it would be okay to do the TAVI with the proper follow-up. So I think that those patients should be treated as the patients with early generation of stent. So we should keep an eye on them after the follow-up.
Yeah. Vinny, did you have a comment on this?
I think this is a slightly complex scenario. One thing we rarely discuss is anticoagulation as well. The whole idea of using a bioprosthesis starts from the concept that you don't want to use anticoagulation. And we have come to I think a pivotal point in the journey of this is if we use different combinations, could be a valve-in-valve or a valve-in-valve with a stent or a TAVR-in-TAVR. If we are going to subject these older patients for anticoagulation, then is that the right approach as well? So I consider a lot of things. Now, any procedure I plan, I try and think of the second intervention more than the first intervention. And I try to get some logic in my head before I start talking to the patient, because that's very important. Susheel highlighted an important point. So we have treated really young patients, like 23, 25 years old with valve-in-valve, because someone was pregnant, for example, and we wanted them to carry through that pregnancy. Or someone wanted to have a treatment for a radical prostatectomy. Although that patient in general was fit for surgery, I would do a valve-in-valve. So we are trying to navigate these complex issues, but I keep in mind anticoagulation risk, also keep in mind the risk of, poor hemodynamics, the risk of reoperation, etc. in my mind at present to come to a safer answer for the patient.
So back to this, the risk of valve thrombosis after valve and valve procedure, Kentaro. Is that because we are oversizing these valves? I mean, we always saw this example with the Sapien 3 valve, which was underexpanded, and that you have some folding of the leaflet, which was probably causing it. Shouldn't we be less aggressive choosing the valve size in these patients?
So thank you very much for your question. So actually, that we don't have that much experience for the valve procedure with Sapien 3. And maybe if we choose the smaller size of the bioprosthesis, and if the valve is the under expansion, so we may see the leaflet thrombosis. So we need to have the further investigation, especially for the small islet patient.
So I have one question to John Webb and John, and you introduced the very diverse type of the TMVR and the new device, and all of the study was some concept of a feasibility test. I think my question is about do you think in the next step is require some random trial if you're gonna do, and what would be some comparator group? Is a mitral clip or surgical part? And how do you think?
It's hard to see how you could do a randomized trial between devices, but clearly these devices all need to be compared to medical management, to surgery, and a mitral clip. I mean, those are the proven therapies we have, the real options, and that's what's happening now. Is that we have trials starting up there comparing patients with mitral clip to one of the transcatheter mitral valve replacements. Now, how long do you need to follow these patients? Well, a long time, isn't it? A couple of years doesn't really tell you the whole story in terms of durability of mitral clip and repeatability with mitral clip versus transcatheter mitral valves. So it's going to be very difficult, I think, to sort this out. The first valve, of course, to get approved is Tenheim. And, arguably this is a valve that has a niche where there may be no competition in terms of very good results potentially in patients with severe MAC, for which we don't really have great options. But most of the other valves are not going to be so great in patients who have severe MAC, and they'll have to come up head-to-head against mitral clip or deal with patients who are ineligible for mitral clip versus surgery.
But that's an interesting question, answer, John, because we know that most of the patient who's going to come forward is patient with secondary mitral regurgitation, and if there's no indication for CABG, there's no guidelines for doing intervention for these patients. We have now seen co-op trial patients actually will benefit from this therapy. So KK, you have a lot of experience with the edge-to-edge repair, and that certainly have been refined during the last 10 years using more clips, newer generation devices. Do you see that there will be a big room for transcatheter mitral valve replacement compared to repair with the edge-to-edge technique?
Thanks very much for the question. I think that's really hard to answer because it depends on what the larger trials will show us regarding the TMVR technologies. My main concern is that for these therapies to reach different shores, it will take a long time, and I think until then the established therapies such as the clip, which has remarkable results given the COAP findings, will remain a mainstay. So I think it remains to be seen, and given the current generations, I would say probably not in the near future. But with a smaller size devices, transseptal technologies, I suspect that day will come and we would have more than one option.
I think, Lars, when we talk about the mitral space, as John pointed out, we have to kind of reconsider a little bit our situation. And I think if still our thesis would be that less invasive will reign supreme, suppose the results between interventional cardiology and surgery are the same or even better. We have a long way to go. And right now, I think we have to be more patient. As John pointed out, there's not one space, not one, except for the clip, not one single space after 11 years that we can match surgery, if we're honest. Not even the replacement, because the replacement situation for surgeons, and I'm speaking about modern surgery, is, you can't compare this still with patient selection that we have to do, the issues that we have for replacement in general, which the surgeons don't have, at least not to that extent, migration, thrombosis, leaks, and all of that. Surgeons usually don't have that. So we are still in our early days here, and I think we're still learning. We're still trying to be consistent. There's no consistency between efficacy between the mitral and the tricuspid. Here we say reduction to 0 is the best. In tricuspids, we say reduction of 2 grades is sufficient. So we are floating around. And I think this is something that we have to kind of settle down ourselves a little bit and be patient and also be fair. Surgeons are not our enemies. Surgeons are our friends and colleagues. And at the end, the focus is on the patient. As much as I support ways to move forward in a very aggressive way, but we also have to say surgery made some significant improvements in their techniques also. They're not sitting back and wait. So everything has to be a little bit reconsidered. All our annuloplasties failed, basically, except annuloplasty devices. With cardiac dimensions, efficacy is a little bit different. But I think this is something that we all did during the last years. We always followed the surgeons. The surgeons told us what to do because they know what they did. We have some kind of reference, and that's what we try to do. I think in mitral, it's going to be a lot more difficult. And maybe we have to choose different options in order to be successful if we try to follow less invasive technologies.
So JJ, as Eberhard was saying, that the outcome after tricuspid valve intervention is much, how should I say, less impressive than after transcatheter mitral valve intervention. What is the reason? Do we find this patient too late? Is there no awareness about the therapy? Or how do you see that path forward?
I think that's clearly the point. We need to better understand patient selection when it comes to tricuspid interventions, because most of the time we are treating patients with failing right ventricle, extremely high pulmonary hypertension. So the spontaneous outcome of the patient is not going to be good. So to clearly understand the overall interventional outcomes in such a population is difficult. So we need to work with the heart failure specialists, even the referring cardiologists, just to get this patient before a too far advanced stage of their pathology. And this way we're going to better understand which are the ones who are going to benefit more from the interventions that we may propose, whether it be a repair or a replacement intervention. But definitely today I have the feeling that we are intervening a little bit too late, and we need to work a little bit on the patient selection to improve the outcomes.
You're intervening too late in these patients, but I guess I would say that we have some really good data coming out soon on transcatheter tricuspid valve replacement, which seems to be fairly reproducible. I think this is going to shift the paradigm here a little bit, where replacement may be the primary therapy for tricuspids rather than repair, at least in more advanced stages.
I think the challenge with the replacement on the tricuspid side, I'm sorry.
Go ahead, Susheel.
No, I think it's very
saying the
important.
replacement on the tricuspid side, the challenge is anticoagulation, right? We know bioprosthetic valves surgically don't last on the tricuspid side. So for an elderly population, yes, I think the data is great about technical success. It's the question of what population are we going to be able to treat. Now, you could argue most of these severe TR patients are probably not going to live 20 years. That population that gets there is probably much shorter survival, but I think that's going to be a much bigger issue on the tricuspid side than on the left side.
So any other questions or comments to this session before we...
Lars, I think, yeah, I I'm just looking at the watch. I think we have reached the end of a very interesting discussion. Lars, you're the more beautiful one, so why don't you take the last word?
We agree with that.
Everybody.
Come on, guys. So I think with this, we had a very great discussion of a lot of aspects, what's in front of us with transcatheter heart valve intervention, both for TAVI in patients with longer life expectancy and also for the mitral and the tricuspid valve. So I think I learned a lot, and I hope it was useful for everyone who attending this session here. And I wish you that you'll join the rest of TCTAP 2021. Thank you.
Thank you. Thank you. Appreciate it. Thank you.